I would like to first of all congratulate the organizers for organizing a single theme academic feast on pediatric liver transplants and giving me the opportunity to speak on a challenging topic, which is the intraoperative anesthesia care in baby less than 10 kgs. And to make the presentation simple, we'll be discussing about the living donor left lateral segmentectomy graft, which is the most common transplantation done in this set of patients. As we all know, the first liver transplant pediatric was done by Dr. Thomas Stahls in Pittsburgh in 1963. Right? However, the child died in the operating room because of uncontrolled hemorrhage. And India's first successful liver transplant was performed in a 20-month-old baby in 1998 by Dr. Rajshekhar and Dr. Soin. And Dr. Soin also has the credit of operating on the world's smallest baby, which was a 2.1 kg from Lagos, operated at Medanta Hospital. About 10% of all liver transplants are performed in children, but it is seen that these days they have excellent outcomes with excellent success due to the good graft and patient survival. And the survival is as high as 90%. But there are substantial differences between pediatric and adult practices. And we should know that child is not a small adult. So we cannot just divide the doses and start giving the child, especially those which are less than 10 kgs. They are a real challenge for the anesthetist. Size match donors for disease donor liver transplants are very few. However, these have been taken care of by living donor liver transplants, reduced and split liver grafting. The challenges are the small size, technical difficulties of the operation, higher rate of the vascular and biliary complications, and post-operative re-explorations or infections. But due to improvement in surgical microanastomotic techniques and superior immunosuppressive regimens, the results are good these days. For anesthetists, these cases are unique because of their age, weight, and liver failure. The fundamental prerequisite for a successful liver transplant in this age group is intensive pre-transplant evaluation, good nutritional buildup, and complete immunization. Body weight is the major determinant of outcome rather than age in this group of patients. And liver transplant in small babies is a distinct subspecialty, and it requires full range of specialty services in a dedicated pediatric unit involving the pediatric hepatologists, the pediatric intensivists, the anesthetists, and the transplant surgeons, who have a thorough knowledge and understanding of the whole process. It's a major procedure and presents us with a formidable challenge. Not everyone's cup of tea, including me. It was very difficult initially, but somehow when it was thrust upon me, I started doing it, and now I enjoy doing it. There is lack of published evidence in these group of patients, so much is based on the experience of the anesthesiologist. The most common indication, as we know, is biliary atresia. I will not go through the preoperative assessment and the investigations as they have been already covered in the earlier lectures. So for each case, a presentation is made in a multidisciplinary team meeting, and the problems specific to the case are discussed and plan charted out for the liver transplant. And specific charts are prepared for the specific case. These include the various inotropic drugs and the other drugs, what is the dilution to be prepared, how much 1 ml per hour will deliver, and what is the usual dose range, so that we are not confused or having problems in the operation theater at the last moment. Similarly, how to correct the electrolytes and metabolic disturbances, the dosage of the various antibiotics and antifungals, what size of tubes to be used, what size of central lines to be used, where the tube is to be fixed. Everything is prefixed earlier in the chart itself, and what are the targets to be maintained intraoperatively, so that everybody is crystal clear in the whole department that what one has to look after. Pre-medication is generally not required for these children. However, you can give IV dextrose and DNS for maintenance during the fasting period, and antibiotics as per the institutional protocol. The most important thing is the preparation of the theater, because once the baby is in, it's very difficult to start preparing after that. So take your time, pre-warm the theater to 25 degrees at least prior to induction. The pediatric airway trolley with equipment have to be kept ready. You have to check the anesthesia machine capable of delivering low tidal volumes and weaning modes. Keep your suction machine, volumetric pumps, syringe pumps, warming devices, pressure bags, everything handy. And anesthetic drugs, infusions, and inotropic drugs have to be prepared as per institutional protocol and kept labeled. You can see here the volumetric pump is very useful in such small children because you should know the exact amount of fluid which you are delivering per hour and also the total quantity of fluids which have been infused. A series of syringe infusion pumps are required not only for giving the drugs but also for transfusing blood and blood products, which have also to be exactly measured and given. The various warming devices include the bear hugger with the blanket and the hemotherm with the warming blanket. You need at least 2 pediatric probes, pulse oximeter, because it may not be when there is hemodynamic instability. At that time, you may have that one of the pulse oximeter is not working and all the things are inside the drapes. You need pediatric ECG electrodes, HME filters, and an infant BP cuff before the arterial line is put in. Both the open and closed circuits are kept ready, and various sizes tube, both cuffed and uncuffed, with airways and laryngoscopes, both straight blade and curved blades, along with LMAs for emergency purpose. Arterial cannulas, central venous catheters, large bore peripheral lines, nasogastric tubes, urinary catheters, cotton roll, sponge, and head ring to prevent alopecia due to pressure, or the pressure points have to be protected. Here you see the 2 central venous catheters. One is 4 French and the other is 5.5 French, preferably 8 centimeters long is used in this group of patients. And for radial arterial cannulation is generally through a 24 gauge cannula, and the femoral line you can use either a 22 or a 20 gauge ladder cath. Induction is individualized based on multiple factors. The problem generally during induction is these children generally have massive ascites, recent history of GI bleed, cardiopulmonary conditions, and hemodynamic instability. Pre-oxygenation is very important because we have seen that the children desaturate very fast, especially if there is a difficult laryngoscopy or intubation. Rapid sequence induction is safer, and most babies come with an IV access through our pediatricians, so IV induction is preferred. Inhalational induction is also possible if there is no IV access. Tracheal intubation is preferably done with a low pressure microcroft ET tube. The problems after intubation may be due to variable pulmonary compliance due to the huge ascites, surgical retraction and manipulation, and prolonged surgery. If using uncuffed tubes, it is better to use a throat pad to prevent either leak or aspiration along the sides of the tube. Fixation is very important. As you can see over here, it has to be double fixed, and please check the air entry on both sides before and after the fixation. It is preferable to cut the tube and avoid catheter mount to decrease the dead space and protection of the pressure points and limb care. Vascular access is a challenge and difficult in small babies. Positioning is very important to open the neck. Either you may keep a pressure bag below the shoulders and inflate it, or you can use sandbags or pillow. Ultrasound is very helpful. In inexperienced hands, it may take very long time, and babies are prone to hypothermia during insertion of the lines if it takes a long time. So mandatory to keep the OT warm and place the baby on a warming blanket. Upper extremities are preferred since the IVC is cross-clamped. It is difficult to assess the peripheral lines, and hence, due to fear of extravasation, fluids are not administered through the peripheral lines or the inotropic drugs, because if there is extravasation, there might be necrosis of the tissue over it. Use of smaller central lines as already prescribed, and it is mandatory to use ultrasound-guided placement because these kids are coagulopathic, and you may have a big hematoma, and it's difficult to place the line if you have punctured the artery. Advantages of central venous catheter being it can be used for CVP monitoring, injection of vasoactive drugs and electrolytes, rapid infusion and transfusion of blood and blood products, and it can be kept for a longer period in the postoperative period. You can use one or two arterial catheters in the radial or femoral or both for both monitoring and sampling. The femoral is more central and reliable. However, in children, many a times you would be requiring to put a jump graft between the aorta and the hepatic artery. So during cross-clamping, the femoral artery gets damped. It is important to nicely secure all the lines and label all the infusion at both ends because nothing is accessible once the child is draped. Here you can see how we have fixed the 2 central lines in the internal jugular vein. The radial artery is cannulated with a 24 gauge cannula and fixed with a splint, and the femoral artery is fixed For maintenance, you can use a mixture of isoflurane, sevoflurane with air and oxygen. Nitrous oxide should be avoided. You should have all the infusions of the inotropic drugs and the vasopressors, calcium, NAC, albumin infusions, and arrange adequate packed red cells and blood products which should be leukodepleted. The goals are to maintain hemodynamic stability, temperature, metabolic, and coagulation parameters. Ventilation strategy is also keeps on differing. It's difficult to deliver tidal volume with massive ascites in the volume control mode. So pressure control mode with higher tidal volumes can be used to compensate the dead space. But you should be careful that once there is drainage of the ascites, or when there is application of the retractors, or when the liver is put, the new liver, there might be increase in airway pressures. Monitoring, as already told, use 2 pulse oximeter probes, frequent ABG, hemoglobin and blood sugar because it's very difficult to assess the blood loss. Urinary catheter with pediatric urimeter, airway pressure, as already told, coagulation monitoring with TEG or ROTEM. The cardiac output monitors are not compatible with these weights. Babies are prone to hypothermia due to the malnourished state, exposure of the abdomen to the ambient temperature, infusion of cold fluids, blood and blood products, cold irrigating fluids from the graft, and the long duration of surgery. Hence, it is mandatory to wrap the baby limbs in cotton roll and special drapes and use the warming devices like hemotherm, bear hugger, HME filter, and the fluid warming devices. Hypoglycemia, hypokalemia, as well as hyperkalemia, hypocalcemia, and metabolic acidosis are all common during the liver transplantation. Hemodynamic instability may be multifactorial due to decreased preload, low systemic vascular resistance, blood loss, massive ascites drainage, retraction of the diaphragm, kinking, clamping, pulling, compression of the IVC, and the manipulation of the liver. Frequent coagulation monitoring to assess the global hemostasis. Full correction of the coagulation parameters is never done in this small group of kids. Correction done only in presence of obvious coagulopathic bleed. So it is prudent that you do frequent inspection of the surgical field and communicate with the surgeon to exactly know whether it's a coagulopathic bleed or a surgical bleed. Maintain normothermia, normocalcemia, and hemoglobin above 8 but less than 10 grams per deciliter. During the pre-anaesthetic phase, there is potential for significant bleeding, except especially in patients who have had Kasai portoenterostomy, and also hemodynamic instability during excessive ascites drainage. The volume replacement should continue to maintain hemodynamic stability, blood glucose levels, and maintain adequate urine output of 1 to 2 ml per kg per hour. Optimize the electrolytes, correct the hypoglycemia and the hemodynamic instability. During the anaesthetic phase, when the diseased liver is removed and the new liver is implanted, we do not have generally problem in this subset of patients for clamping of the inferior vena cava. They are hemodynamically stable. However, there is worsening of acidosis, hyperkalemia, and hypothermia, which is significant in this phase, along with hypoglycemia and hypocalcemia. Do not overhydrate the child at this stage because it may lead to graft edema post-reperfusion. During reperfusion, the circulatory system is exposed to cold fluids, potassium ion, and ischemic factors coming from the graft, leading to hypotension, ventricular dysrhythmias, and bradycardia and air embolism, and bleeding from the raw surface. But be prepared and correct all the metabolic abnormalities, ionized calcium, potassium within normal range, and normothermia. Temporary administration of 100% oxygen and with reduction of volatile agents, stepping up of inotropes, with small bolus of calcium, sodium bicarbonate, and phenylephrine can mitigate this post-reperfusion syndrome. It is better to flush the graft with normal saline or ringer lactate so that the post-reperfusion syndrome is minimized. Portal vein is attenuated in these pediatric patients and may have to be redone even multiple times, and we have to be ready for multiple reperfusions and multiple Dopplers. During the neohepatic phase, there is completion of the arterial and biliary anastomosis. However, the coagulopathy may continue, and there may be oozing from the raw surface and the anastomotic sites. So continue with the volume resuscitation and blood transfusion. Maintain hemoglobin below 10, otherwise there is a risk of vascular thrombosis. Look for good graft function in the form of decreasing acidosis, improving lactates, stabilization of the blood sugar, and good bile production, and good urine output and temperature maintenance. Doppler ultrasound is done to confirm vascular patency. Biliary drainage mostly needs hepatogenostomy, so the duration of the surgery may be further prolonged. NAC, alprostadil, and heparin infusions may have to be started. Abdominal closure may be difficult due to the large size of the graft, and it may have to be closed in stages. The primary closure of abdomen may compromise the flow of hepatic vessels and may cause compartment syndrome, and the airway pressures may also increase. Traditionally, these babies were electively ventilated as vascular imaging was done frequently to check patency, and it was difficult to assess in a restless and agitated baby. There was high rate of re-exploration and prolonged use of sedatives and tight abdominal closure. However, with advancements in surgical and anesthetic maneuvers and techniques, recently fast tracking, that is on-table or early extubation, has shown favorable results if they fulfill certain criteria like absence of encephalopathy pre-op, hemodynamic stability, confirmation of vascular patency on Doppler, stable blood gases, absence of tight closure and massive transfusion, and good graft function. Problems of elective ventilation is that sedation and paralysis are mandatory. There are chances of endobronchial tube migration or accidental extubation or chances of mucus plug causing collapse of the lung. Post-operative period will be discussed in the next presentation by Dr. Ravi Raya. So the take-home message is emphasis of anesthetic management in small children should be on monitoring blood loss, which may be massive and rapid. Hypothermia must be prevented. Impact of reperfusion may be considerable, so ensure hemodynamic stability. And the electrolytes, glucose, and acid-base status must be controlled. The anesthetist involved in surgery for liver transplant may make the difference between a good and poor outcome for both the child and the transplanted organ. And it does not only involve high-end surgical performance, but also close interdisciplinary perioperative cooperation based on strong standard operating procedures focusing mainly on fluid management, hemostasiology, and strict monitoring of vascular patency. These are certain babies whom we extubated on table after the liver transplant. Thank you very much for your patient hearing.